there is to blood leaving the heart. That there's an afterload for the blood to leave to the systemic circulation, and there is an afterload, a resistance for blood to leave the pulmonary circulation. All of these impact whether we have a decreased cardiac output state. Why we see emergencies as cardiac emergencies all comes to deal with whether the heart is pumping out enough blood-carrying oxygen and nutrients to fulfill the needs of the body. So the causes of cardiac emergencies, I would break them into two basic categories, or maybe three. One is the heart rate, and under those are arrhythmias, either a bradycardia, a bradycardic arrhythmia, or a tachycardic arrhythmia. Then there is cardiac output. Is there a contractility problem with the heart? We see that in dilated cardiomyopathies. In cardiac output for a left-sided congenital defects or coronary insufficiency. Is there an oxygen carrying capacity problem? Are we not getting enough of the blood flow to the lungs to become oxygenated? So we have enough cardiac output, but it's not carrying enough oxygen. And we see that in right-sided lesions and great vessel abnormalities. So let's start with the arrhythmias. Heart block is one that we see quite often, and this is typically in newborns. We'll even see this as starting to show problems in utero as we do fetal echocardiograms, and we see major problems when children typically are children of mothers with SLE, and we'll talk about that a little bit later. But we see heart block, we have cardiac output equals heart rate versus stroke volume, and children are very heart rate dependent, and they do not tolerate bradycardia very well. They don't have a lot of ability with a stiff, small heart to increase their preload. They can't increase their stroke volume, so they're very heart rate dependent. Those with tachyarrhythmias, the tachycardia decreases the filling time. Therefore, even though the heart rate is elevated, the stroke volume is so low that the cardiac output drops. So that's with arrhythmias. So if we look specifically at heart block, it's congenital, a complete heart block. I've shown an EKG on the screen. You see that the P waves run through, and we have basically either a septal escape rhythm, or we get a ventricular escape rhythm. And most likely, this is seen in infants, as I said, with mothers of lupus. The problem is the slow heart rate leads to decreased cardiac output. And the only treatment for this, really, because we don't have a lot of other good options except putting them on maybe a long-term beta agonist, is a pacemaker. So next, I'd like to go into tachyarrhythmias, and there are two different types of tachyarrhythmias that you might come across when a patient shows up in the ER and they're in extremis. There's the automatic type, where there is basically another site that's generating a competition with the sinus node, and those are examples of that are multifocal atrial tachycardias or right ventricular outflow tract ventricular tachycardias. Immediately to the right on your screen, you see that this is a multifocal atrial tachycardia, and you see multiple different types of atrial waveforms. And this child is very tachycardic. He's in really close to 300 at this point. Bouncing back and forth, though, it won't be regular at all because you'll have very many pacemaking cells competing with each other. And then the re-entry type, which is probably what we see most of, is when children come in and they have some type of re-entry type tachycardia, whether that's a superior ventricular tachycardia, an AVNRT, or an atrial flutter. I saw a child come in and we thought for sure he was just an SVT, just regular AVNRT re-entry, until we started to slow him down. But this kid came in when I was in training, and he was very sick. He had a heart rate over around 150 to 160, but he was in heart failure. And so we thought, is it cardio? What is this that he has? Is this cardiomyopathy? Is he tachycardic secondary to poor cardiac output? And so his body is driving him to beat faster. But what we found is that when we slowed him down and we gave him some treatment, we actually saw that he was in atrial flutter. And that long-term atrial flutter, over 100 beats per minute, had caused him to go into had caused him to have cardiomyopathy, tachycardia-induced cardiomyopathy. So the problem with these tachyarrhythmias is decreased cardiac output, and that long-term effects of tachycardia can cause a cardiomyopathy. The treatment, as you know, is cardioversion or medication. Sometimes we like to, if the kid is not an extremist, we like to give medication sometimes before cardioversion. Beta blocker or esmol, which is short-acting, will often be used, and then we treat with cardioversion. That often helps to hold the cardioversion once we treat in these situations. The automatics, the multifocal atrial tachycardias and the right ventricular outflow ventricular tachycardias, they don't respond to cardioversion very well, and usually they require medication. Infectious causes. The number one cause we see in children are the viral cardiomyopathies. I believe that in Iraq you have an increase in metabolic types of cardiomyopathies, more so than we do in the United States. But I still believe that viral etiologies for the cardiomyopathies, for the dilated cardiomyopathies, is the most common. And what this is the heart muscle is directly affected, and so we get poor contractility. So with that poor contractility, we have decreased stroke volume, and so usually what the heart will do is it will increase its heart rate to try to compensate for a lower stroke volume, but it cannot increase it enough, and so these children will often present to us very, very sick. The congenital defects that present at birth are the left-sided defects, aortic or mitral obstruction, hypoplasia, all the way to atresia, hypoplastic left heart syndrome, right-sided lesions such as pulmonary atresia or tricuspid atresia, and defects of the great vessels, either transposition of the great arteries or the total anomalous pulmonary venous return with obstruction of flow. These are the ones. Now, there are many other defects that present and may cause difficulties, may cause cyanosis. I'm trying to concentrate on the ones that appear to us as emergencies. And so these are the most common ones that I have come in contact with, but we all have examples of, well, this kid, I had a kid recently show up in the ER, and he was very, very sick, and they weren't sure what was going on, and so they asked me to come down, and mom and dad just said he was doing fine. He was about 3 months old, and then he just started looking pale and clammy, and they brought him in. The ER docs were very, very concerned. I had the echocardiograph tech meet me in the ER, and when I put the echo on, what I saw is that he had congenital mitral stenosis, and he had done okay for a couple of months, and then he decompensated. And so sometimes what you can see is the mild things, they don't always present at birth, and they can sort of wait, and over time the kid does fine until there's some change in the physiology. Maybe the pulmonary vascular resistance decreases, and then they come into extremis. So let's look at each one of these individually. For left-sided lesions, we have hypoplastic left heart syndrome. Is sort of what we use to sort of describe many things. Severe aortic and or mitral valve defects with or without LV hypoplasia are the typical left-sided lesions. The problem is that there is an obstruction to systemic inflow to the left heart or outflow out of the left heart, and so we severely compromise cardiac output to the systemic circulation. The treatment for this situation is to maintain fetal, or what we would call ductal circulation, so that the blood coming out of the right side of the heart can continue to go through the duct and feed not only the descending aorta, but the ascending aorta, including the coronaries, to continue blood flow to the heart itself. The next lesions that we look at are right-sided lesions, severe pulmonary and or tricuspid valve defects with or without right ventricular hypoplasia. The picture I shows pulmonary atresia with tricuspid stenosis and RV hyperplasia and hypertrophy. The problem is there's inadequate pulmonary blood flow. So this would be an issue of lack of good oxygen carrying capacity of the blood due to the cyanosis, because the majority of the blood is just circulating in the systemic circulation and is not able to go to the lungs to pick up oxygen. So the main problem is there's inadequate pulmonary blood flow. So what is the treatment? It's to maintain fetal or ductal circulation until surgical intervention is possible. I know that's a challenge. I know that in Iraq, you're starting to use prostaglandins to maintain ductal pendency. But these emergencies, sort of, not only do you need prostaglandins to maintain ductal patency, but you also need a surgical plan to how to be able to treat them, for instance, with a shunt. So the next congenital lesions that really often present in emergencies at birth are detransposition of the great arteries, or TAPVR. And so with the transposition of the great arteries, if there is an atrial mixing, then what happens is all the blood that's coming back from the lungs goes back out to the lungs. So the pulmonary artery is connected to the left ventricle. The left atrium brings the oxygenated blood in the left ventricle, and then it goes out through the pulmonary arteries, then back to the heart. So you see there's a circulation that never crosses. And likewise, all the blue blood comes back to the right atrium, goes in the right ventricle, out to the aorta, then comes back to the right atrium. So in these situations, if we don't cause some mixing of the blood, these children typically will die and will often present quite blue and in extreme situations. The opposite side, so rather than outflow, looking at the inflow, the major emergency that we see in TAPVR is those that have typically inferior connections, and those usually are increased for obstruction. We can have kids with TAPVR that might show up. I've seen some present as late as 2 or 3 years of age, because they were not desaturated. The obstructed TAPVR, those kids usually present at birth and they're quite sick. Both the treatment for both of these, for the detranspositions and atrial septostomy to allow mixing of the blood, and then surgical treatment as soon as we can, usually within the first month of life. TAPVR, it is one of the true surgical emergencies if they are obstructed for emergency surgery. It's the one time that I'll call a surgeon in the middle of the night and say, you have to come in, and because I can't do anything for this baby until you unobstruct the veins. The next are congenital defects, but we see them postnatal. We don't see them typically at birth. And the classic one for this is alcap, or anomalous left coronary artery arising from the pulmonary artery. The problem happens as the pulmonary vascular resistance decreases over the first couple of months of life. And these kids typically show it between 3 and 6 months of age. As it decreases, there's decreased flow into the left coronary artery, and the resultant effect of that is ischemia. With ischemia of the left heart, we have decreased contractility, we have dilation. You'll have often ischemia of the muscles that control the mitral valve. And so the mitral valve starts to leak, the contractility is down, the stroke volume is down, and they come in quite sick in basically florid heart failure. The treatment, you can stabilize these children, but the real treatment is reimplantation of the left coronary artery into the aorta. The surgeon takes it off of the pulmonary artery and moves it over to the aorta. And usually these children will resolve their cardiomyopathy pretty quickly once we get oxygenated blood to the left side of the heart. Another acquired defect is from Kawasaki's disease. It's a vasculitis that can cause coronary dilation and rupture or obstruction. I saw a child who came in. He was outside. He was 5 years old. He had a history of Kawasaki's disease with dilated coronaries. giant aneurysms of the coronary arteries. And he came into us basically pale, diaphoretic, and he looked like a 5-year-old having a heart attack. We did EKG. He had ST segment elevations. It was when I was in training, and I talked to my senior, and I explained to him, and I said, I think we actually have to do heart surgery on this kid. And unfortunately, my senior said, no, I don't think so. We'll just wait till tomorrow and we'll talk to the surgeons. Well, when the surgeons came in and we talked to other cardiologists, they said, well, why did you wait on this child? This child needed emergency surgery. He's completely obstructed his left anterior descending artery. It was a very difficult situation for myself, and feeling like I didn't have the power, even though I realized what this child needed to have done. And so the problem is that with this large aneurysm, you can either have rupture or you can have clot form within the vessel itself, and then that will decrease blood flow to parts of the heart. You get ischemia and poor contractility, decreased cardiac output. And the difficulty with Kawasaki's disease and these giant aneurysms, you actually start killing heart muscle that you may not get all that back. So the treatment is surgical revascularization at the time, especially at the time of symptoms. And usually we have a number that we use. If the aneurysms are so large, we'll usually treat them before they have symptoms because the risk is so high. The keys, as we look at children who present with cardiac emergencies, is one, the proper diagnosis. You're not going to know how to treat these children unless we have the proper diagnosis, and that this needs to be accomplished as soon as possible with the best person you have to make the diagnosis. We can make a lot of mistakes with this, with our treatments, if we don't know what we're doing. Often we'll do the standard things for non-cardiac children. Before we start treating children with cardiac defects, we really need to understand what we are treating. The prompt treatment that we start out with is basic advanced cardiac life support appropriate for pediatrics or PALS. We should get an ECG and a echocardiogram as soon as possible. We have to do the things for stabilization. Does the child need to be intubated? They probably will need a central line, and then we need to decide, as we start getting more information, as we stabilize the patient, will they need cardioactive medications? And then is surgery indicated or not? And do we have the ability to do the surgery in our location, or do we need to start looking at transferring the child either out of our city or out of our clinic into to a higher advanced level center, whether that's in our country or outside of our country? The proper, and we really need to make sure that we have proper monitoring during the recovery phase. We need to watch these children very, very closely, even for those that maybe they have come in with a tachyarrhythmia and we're able to give them a medication and we break the tachyarrhythmia. We need to watch them closely and decide what we're going to do to keep them from going back into this emergency situation. So that's where I'm going to stop. And I just wanted to show a couple of pictures. It's an honor for me to be able to speak to you guys, because I love the country of Iraq. And I just wanted to show you that here's myself. My wife is a pediatric cardiac anesthesiologist, and this is us with Dr. Faraz in Fallujah. This is us with Dr. Mohammed, with Dr. Mary Porsche in Tikrit. This is us with Dr. Mohammed in Karbala. And this is us with Dr. Kamal with the surgical team as well in Dohuk, with Dr. Allison Sabalka from Mayo Clinic. And this is us with Dr. Asa, who's the original cardiologist I got to work with in Iraq. It continues. I think I've done probably 25 missions with him by now. And he continues to be an inspiration to me for his love for the children of Iraq. And this is a picture of my lovely wife. She is an incredible clinician, and if it weren't for her, I wouldn't be able to be doing all the things I do, because she is a valuable member of the team. So with that, I'll stop and willing to answer questions if that's appropriate for the time frame.
Thank you, Dr. Kirk. Thank you for your nice about Iraq and everybody and things you are done for the country. Thanks for your helps. And now we are shifting to the second speaker, Dr. Sausan from